It's a pleasure to start this section on acute pancreatitis with my co-chair, Joanna Lakkaurinen. And the first talk will be delivered by Sanjay Pandanamboyana from Newcastle. And Sanjay did a lot during the pandemic on the association between COVID and acute pancreatitis, and this will be the topic of his talk. So please, Sanjay, the floor is yours.
Hello, everyone. I'd like to thank the European Pancreas Club Organizing Committee for asking me to give this presentation on SARS-CoV-2 infection and acute pancreatitis. What is the current evidence and where we stand with regards to dual SARS-CoV-2 infection and acute pancreatitis? I'm Sanjay Pandanamboyana. I'm a hepatobiliary pancreatic and transplant surgeon at the Freeman Hospital in Newcastle in England. I also hold a position of associate professor at University of Auckland in New Zealand, where I worked previously before moving back to England. I am a member of the clinical abstract selection committee of the EPC. I don't have any financial disclosures. So at the start of the pandemic in 2020, there was quite a bit of evidence to suggest that the receptor through which SARS-CoV-2 infection causes damage is the ACE receptor, and one of the reasons why lung injury is so common is because of high expression of ACE receptors within the lung. But there was also evidence coming from China suggesting that the expression of ACE receptors in the pancreas was much higher. In fact, the expression of ACE receptors in the pancreas was much higher than what is seen in the lung. And I did a exploratory review at the time in the BJS in 2020, where we identified that the expression of ACE receptors in the pancreas was high, and the ACE receptors, the cell entry receptors, which is ACE, but there were also other cell entry receptors within the pancreas like TMPRSS2 and neuropilin. These cell entry receptors of the COVID virus were expressed not just on the islet cells, but also on the pericytes and also the ductal cells of the pancreas. So there was some evidence to suggest, yes, all these receptors are expressed in the pancreas. And what does that mean? Does that mean the pancreas is at risk of damage because of the COVID virus? Most of the results we were getting at the time were from smaller studies from China and a couple of studies from America and small series from the UK. But there was no larger study to clinically confirm that potentially SARS virus can cause acute pancreatitis. We then thought it would be the right time to undertake a multi-center collaborative study because the number of patients with acute pancreatitis and COVID was relatively small. So we undertook this study from the Freeman Hospital in Newcastle. It was a multi-center international study. We got support from AUGIS in the UK and also from the Pancreatic Society of Great Britain or Ireland, and the trainee group in the UK, which was the RU group. So the study was a success, and we managed to recruit centers, 52 centers, both in the UK and 4 centers in Europe and 1 in Asia. And the results were published in Gut. So although the results were published more than a year ago now, we never formally presented the results, and I thought it would be a good opportunity to present these results at the EPC meeting. So what we found was, or the period of 4 months, which was the recruitment period, which was right at the peak of the pandemic in Europe, we recruited 1,777 patients with acute pancreatitis, of which 149 patients had both pancreatitis and COVID, which gave a prevalence of 8.2%. At that time, laboratory testing was not available in all hospitals in Europe as soon as the patients came into the hospital, so we used World Health Organization case definition for confirmation of COVID-19 infection. So 80% of patients out of these 149 had confirmed cases, which were confirmed by laboratory swab testing. 10% were probable cases where they had clinical criteria and chest imaging. And another 10% of patients were suspicious, where the diagnosis was based purely on clinical criteria alone. But the majority of patients were confirmed cases on laboratory testing. So what we found when we did the baseline characteristics was summarized in the slide is patients who were saw COVID-19 positive had predominantly moderate to severe pancreatitis or severe pancreatitis based on the revised Atlanta criteria, and also they were high at risk of ARDS. And this reflected in the number of patients who required necrosectomy. The necrosectomy rates in the COVID positive group were much higher compared to COVID negative group. 5.5% in the COVID positive group and 1.3% in the COVID negative group. And then we did unadjusted and adjusted analysis comparing those 149 patients with the remaining patients. And when we did the adjusted analysis, what we found was patients who were COVID positive and had acute pancreatitis were at higher risk of ICU admission. The 30-day mortality was high, the length of hospital stay was high, and they were also at higher risk of persistent organ failure. In fact, the 30-day mortality in the dual group was about, odds ratio was 2.4, and the persistent organ failure odds ratio was 2.7. So there was a substantial risk that patients who had COVID-19 and acute pancreatitis were at higher risk of mortality and organ failure. When we looked at the type of organ failure and mortality, what we found again was respiratory failure was the predominant organ failure. And respiratory failure was again the main cause of death in the COVID positive patients, which is expected in a way because of the associated lung injury. And the 30-day mortality, as I said, was substantially higher in the COVID positive group. So in this slide, we summarize the results. As I said earlier, the mortality was high, the organ failure was high. What we did find was the higher number of patients with severe acute pancreatitis, which we could not really explain. Why is the reason these patients were at risk of severe acute pancreatitis in the COVID positive group? Is that because of additional pancreatic injury by COVID-19, in addition to lung injury? But we could not really explain as to the reason. We can only speculate potentially that pancreas could be affected by COVID-19 and pancreatic injury could be caused by COVID-19, resulting in a higher number of patients with severe acute pancreatitis and necrotizing pancreatitis. So we then looked at the etiology of acute pancreatitis in the cohort to see if there was any evidence to suggest COVID-19 can result in a higher number of idiopathic pancreatitis if it was presumed to be a cause for pancreatitis. The idiopathic pancreatitis rates were slightly higher in the COVID positive group, but there were a significant number of patients with unknown etiology of pancreatitis in the COVID positive group. You have to remember this was right in the middle of the pandemic. Not many hospitals were doing endoscopic ultrasounds to rule out microlithiasis. Not all of them were having MRCPs prior to discharge. So the unknown etiology was a big chunk of patients for which we didn't have a cause of pancreatitis. So we thought it was the right time to do a follow-up study, and this was the follow-up study of the original cohort. We followed all patients up for a period of 6 months to identify an etiology of pancreatitis. So the follow-up study was good success. Again, the follow-up study was published in Gut, where we looked at 1,400 patients out of the 1,700. So we managed 90% follow-up of the original cohort, looking at the etiology where they've completed all blood investigations, including testing for hereditary pancreatitis, testing for microlithiasis, as well as MRCPs to rule out pancreas divisum, etc. And what we found in the results was the idiopathic acute pancreatitis rates were much higher in the COVID positive group, 34% idiopathic pancreatitis versus 13% in the COVID negative group, with a significant higher risk of idiopathic pancreatitis in the COVID positive group. So for the follow-up study, we know that there is a high risk of idiopathic acute pancreatitis, and potentially suggesting that maybe COVID-19 can cause pancreatitis. But again, this is all clinical data and a lot of speculation, but we needed some laboratory data to confirm the association. And it comes down to, again, the ACE receptors. So the ACE receptors are expressed within the pancreas. And does that mean can COVID-19 cause acute pancreatitis? So we then looked at what laboratory evidence was published around that time. And until now, I've recently looked at what's the laboratory data we have. So the laboratory evidence at this point of time suggests COVID-19 can infect human stem cell-derived pancreatic cells in a laboratory setting. If you get stem cells from pancreatic cells, derived pancreatic cells, and infect them in a laboratory setting with COVID-19, they can be infected with COVID-19 virus. And the COVID-19 virus can be replicated in beta cells of the pancreas, which can then cause impaired glucose stimulated insulin secretion. We have seen in this at the start of the pandemic, quite a few number of patients when they had COVID-19 infection in ITU had difficulty in maintaining glucose balance within ICU setting, and this can be explained by the fact that virus can affect the beta cells and cause impaired glucose stimulation. And when we looked at the autopsy of patients with COVID-19 infected patients, we could see coronavirus in the nucleocapsid protein in the pancreatic exocrine cells, beta cells, and in close proximity to the islet cells. So there was laboratory evidence to suggest potentially COVID-19 virus can infect and damage beta cells, but still there was no evidence to suggest it could damage acinar cells, because damage to the acinar cells is what we need to develop pancreatic inflammation and injury. And that is something which still need to be proved. And that may or may not be possible in the laboratory setting, because islet cell isolation may damage ACE receptors and TMPRSS receptors, and that might reduce their susceptibility to viral infection. Infection of islet cells within an intact isolated islet has been difficult to do in other viruses, so it might not be possible to do it with coronavirus as well. And we still do not know if we still manage to show that islet cell can be damaged in a laboratory setting. We do not know what the effect of that in a vascularized innervated islet of the human pancreas is. So we still cannot categorically say at this point of time, coronavirus can damage the islet cells and can result in pancreatic inflammation. But we may have to then rely on epidemiological studies to provide indirect evidence that over the last 3 years, has the incidence and prevalence of acute pancreatitis, has it gone up in the UK and Europe? So that can only be answered by epidemiological studies. And we are currently doing an epidemiological study in the UK to see if that is the case by looking at coronavirus infection rates before, during, and after the pandemic. So where does that leave us with? To confirm that a virus can cause disease, they have to fulfill Koch's postulates for whether it's a bacteria or virus. At this point of time, we have data to fulfill 2 of the 4 Koch's postulates, that coronavirus can be identified in the pancreas of infected patients, and coronavirus can infect exocrine and endocrine cells ex vivo and in vivo. But to be able to confirm the other 2 postulates, we have to inoculate samples of coronavirus into human subjects to reproduce the disease, and then isolate the virus from those inoculated subjects, which may not be fulfilled because of ethical reasons. So at this point of time, we can only conclude that coronavirus infection in patients with acute pancreatitis increases disease severity, increases mortality, and there is some laboratory evidence to suggest coronavirus can damage the beta cells of pancreas and cause difficulty in hemostatic balance of blood glucose, but still no confirmatory evidence that it can cause damage to islet cells and cause pancreatic inflammation and injury. And only epidemiological studies may answer some of the questions we still have regarding the etiology of pancreatitis as COVID. I would like to thank again the EPC organizing committee for giving me this opportunity to present this data and current evidence on COVID-19 and acute pancreatitis. Thank you very much.
Hi, thanks, Sanjay. Great talk, and nice to see you, even if virtually. I'll start with the question. Did you think of the possibility of, let's say, an ischemic vascular damage to the pancreas? Because we've seen a lot of, through the GI tract, ischemic damage in COVID patients. So that could be another explanation different from the direct infection of the pancreatic cells.
Yeah, it is. That's a good question. It is possible. I think that could also be an explanation why the mortality and the outcomes in the COVID pancreatitis group was worse. You get a cytokine storm with acute pancreatitis, and you get a cytokine storm and exaggerated inflammatory response with COVID-19 as well. And that's what they showed with the recovery trial. You give them dexamethasone, their outcomes are better. So we know that. So it is likely that the combination of 2 cytokine storms exaggerated by COVID infection may have made the disease process worse in the COVID positive patients. It was still difficult to explain why the number of patients with necrotizing pancreatitis was much higher in the COVID positive group. There were substantial differences. So there are still some unanswered questions, and there are a number of viruses and bacteria which can cause pancreatitis. So I think this is still a work in progress. And hopefully in the next few years, we'll have an answer to this and whether or not it's a cause of pancreatitis, the COVID-19 virus.
Thanks a lot. I think we need to go to the next talk. So Joanna, please, you're going to introduce.
Yes, thank you. Next talk will be given by Professor Vincent Rippers, and we go to a fairly rare etiology of acute pancreatitis, and that is hypertriglyceridemia induced disease. So very, very interesting to hear this talk, and Vincent, the floor is yours.
Dear Chairman, dear friends, I'm very happy to be with you and to propose this lecture about hypertriglyceridemia induced pancreatitis. So here are my financial disclosure. So just first, to begin, I want just to remind you that hypertriglyceridemia can be due to primary form, I mean monogenic mutation, which is represented by a very rare disease, FCS, familial chylomicronemia syndrome, which is represented by just 1 or 2 persons per million of inhabitants. So it's mainly due to lipoprotein lipase insufficiency. But the main cause of hypertriglyceridemia is due to polygenic form. I mean, it's an association of genetic abnormalities and risk factor. And at the top of risk factor, I know that you know very well, that's chronic alcoholism, and then diabetes type 1 and 2, and metabolic syndrome especially, pregnancy, renal failure, and some kind of medication. And at the end, the third cause, which is very, very rare, it's autoimmune disease. So it means that in case of familial chylomicronemia syndrome, there is usually a lack of lipoprotein lipase function, which results from recessive loss of function in gene coding for LPL, I mean lipoprotein lipase, and its modulators. But in case of multifactorial chylomicronemia syndrome, there is an association with secondary factors as chronic alcoholism, pregnancy, diabetes type 1 and 2, etc. So in case of hypertriglyceridemia-related acute pancreatitis, it means that there is severe hypertriglyceridemia, more than 10 grams per liter, which means that there is presence of chylomicron. We have to know that there is chylomicron have a very, very short half-life. That means that we have to propose a very early triglyceride dosage when people arrive at emergency room. So in case of triglyceridemia more than 10, there is a lactation serum, as you can see in the picture. And we say that triglyceride level leading to acute pancreatitis is around 3 to 100 grams per liter, with a mean around 10. So what is exactly the pathology? There is 2 different kinds of mechanisms. The first one, it is a direct toxicity of triglyceride on acids. There is a toxicity of free fat acid. And the second mechanism is ischemia mechanism. I mean, the high level of chylomicron in the vessel can lead to microthrombi and, of course, to ischemia. So what is the incidence of hypertriglyceridemia acute pancreatitis? Regarding this cohort of patients in Chinese population, we can see that there is a rising incidence of hypertriglyceridemia acute pancreatitis, and it was the third cause of acute pancreatitis in this cohort, and it represents around 7 to 8% of all the causes of acute pancreatitis. So what is exactly the risk of acute pancreatitis, and is it correlated to triglyceride level? In this population study, in more than 100,000 patient individuals in general population, we can see that the risk of pancreatitis was clearly correlated with the serum level of triglyceride, and especially in a patient with more than 5 grams per liter. And when we adjust this risk regarding age and sex, or regarding alcohol intake, or BMI and diabetes, the risk is still correlated with triglyceride level. And for example, in this case, after adjustment on diabetes and BMI, if we have triglyceride level more than 5, for example, the risk to have acute pancreatitis was 5.8. So now when we look to a cohort of patients with severe triglyceride level, we can see in this population of more than 5,500 patients with severe hypertriglyceride, we can see that around 5% of this patient develop acute pancreatitis. So it means that there is some kind of different risk factors which lead to acute pancreatitis. And this, in this risk factor, we can see that to have a history of past pancreatitis is really risk factor to have some kind of relapse with a risk around 9. And of course, the level of triglyceridemia, serum triglyceridemia, more than 10 grams by liter. So now what is the outcome in patients with hypertriglyceridemia acute pancreatitis? We know that it can lead to ischemia and of course to severe pancreatitis. And it's clearly confirmed in this study. In patients with severe and very severe level of triglyceridemia, there is a proportion here to have some persistent organ failure was around 48%. And when we look further and we compare patients with triglyceridemia less than 1.5 versus patients with triglyceride more than 10, we can see that there is clearly a higher risk to go to intensive care in patients with very high level of triglyceride, more than 60%, of course, a higher rate of 3% versus 8%, and a higher rate of necrosis, 50% versus 36%. So these data are this cohort of patients with more than 1,500 patients, and clearly the risk of organ failure was also associated with the level of triglyceride, and clearly in case of severe and very severe level of serum triglycerides, there is a higher risk of organ failure or mortality, for example. So the other question is if this kind of acute pancreatitis are more severe compared to other causes. And in this meta-analysis, which was composed by 15 studies, comparing patients with acute pancreatitis with or without hypertriglyceridemia, we can see that the fact to have hypertriglyceridemia can lead to more renal failure, respiratory failure, systemic inflammatory response syndrome, and of course, mortality. So these data were confirmed by this series when they compared patients with acute pancreatitis due to biliary or hypertriglyceridemia. In case of hypertriglyceridemia, the level of the CT score index was more important, and it was exactly the same for mortality. So what is now the treatment for acute pancreatitis in hypertriglyceridemia? The treatment is exactly the same. I mean, organ failure management, intensive care if needed, hydration, analgesic. but we have to look to hyperglycemia. If there is hyperglycemia, of course, intravenous insulin protocol have to be proposed. But if there is no hypertriglyceridemia, it was proposed 2 different strategies with glucose and insulinotherapy just to improve lipoprotein lipid synthesis by the fat tissue, and heparinotherapy, because the rationale was to recruit some LPL, which is localized in endothelial cell. But these 2 different strategies were not recommended or are clearly debated in the literature. So is there a place of indication for apheresis? So clearly there is no consensus regarding this recommendation, but it has to be discussed to propose this treatment in case of patient with no controlled hypertriglyceridemia and organ failure for a patient just after 2 or 3 days. So now, is there a specific diet for this patient? In case of primary form, I mean monogenic, we have to propose a diet which is extremely difficult to maintain, because it means that patients have to eat only an ultra very low fat diet, less than 10%, it means less than 20 grams per day, which is very difficult to observe with a very poor and long-term compliance, and impacts lifestyle. So it's very difficult. For the polygenetic form, I mean the association of the genetic abnormalities and the risk factor, we have to treat the cause, and we have to manage the cause. I mean chronic alcoholism, diabetes, pregnancy, renal failure, and so on. So in conclusion, in case of hypertriglyceridemia related acute pancreatitis, we have to know that the severity is usually correlated with the triglyceride level. There is a very high risk of relapse in case of patients who have a past medical history of acute pancreatitis. Necrosis and organ failure are very frequent, and of course mortality and severity are probably higher compared to other causes of pancreatitis. So it means that for this kind of patient, we have to propose normally and usually a multi-approach to take care of this kind of patient. And all these kind of people have to be involved. I mean, lipidologists, dietitian, patient, family, and pancreatologist, of course. So thank you very much.
Thank you, Vincent, for an excellent talk. Thanks a lot, and great to see you there, almost in person in the video. I don't see any questions in the chat, and by the way, I would like to encourage everyone to please write your questions to the chat, so we will ask them with Gabriele from the speakers. But I would like to ask about your routine in your clinic. When you see that the patient is having etiology which is non-alcoholic and non-biliary, is it your routine to check from every patient the triglycerides and calcium and of course IgG4, for example, or do you do some sort of selection at that point?
So for this patient, and especially for hypertriglyceridemia, we have to check every patient when they arrive at the emergency room. As I explained, the chylomicron half-life is very, very short, 1 or 2 hours only. So it means that if you test hypertriglyceride serum level 2 or 3 days after acute pancreatitis symptoms, it could be normal. And that's why if specifically you don't find any reason to acute pancreatitis, I think it's a good reason to repeat serum level testing a few days after or weeks after the episode, just to be sure that there is no problem of triglyceride level. For the other course, we are used to check calcium level. For IgG4 level, we selected really the patient because it's a specific, very specific autoimmune pancreatitis, and usually there is a specific context and a specific imaging. And in case of hypertriglyceridemia, usually pancreatitis is quite very severe with necrosis and so, and it's really not the case for autoimmune pancreatitis. So it's, I think, completely different.
Mm-hmm. Yeah. Exactly. Yeah, now we do have some questions in chat, and let's take at least this first one, which is, are there particularly damaging types of triglycerides? Are there particularly damaging free fatty acids, for example?
Yeah, so it's so there is a lot of necrosis pancreatitis in case of hypertriglyceridemia. There is a really direct toxicity on the acinar cells due to fatty acid, which is due to metabolism of chylomicron. So there is really a direct toxicity. And why is there so many necrosis pancreatitis? It is that there is also ischemia mechanism. Chylomicron are very big molecules, and it leads to microthrombi. That explains that there is so many necrotic pancreatitis.
Yes. Okay, thank you very much. And Vincent, could you please, there's 2 more questions in the chat. So if you could reply to those questions in the chat, that would be great, so everybody can see. And in the interest of time, I think we will go now forward. So Gabriele, please.
Thank you. Great talk. Thanks. So we go to the next talk from Professor Stimach, and he will talk about modern treatment strategies of acute pancreatitis. So please, Davor, the floor is yours.
Dear colleagues and dear friends, I will talk about the new therapeutic methods in acute pancreatitis. At the very beginning of my lecture, I would like to give my support to Ukrainian colleagues, and it's a pity that we are not at the moment in Ukraine, but I hope that the Congress will be successful. So I will talk about new therapeutic methods in acute pancreatitis. What happened in the last 2 years? I think that this was changed in the last 2 years is that we have a lot of publications, a lot of papers, but not so many new things comparing to what happened 2 or 3 years ago. So I will do an overview of therapeutic methods in acute pancreatitis. I will start with the first symptom of acute pancreatitis. It is a pain. So because the first symptom is a pain, and it is a leading symptom for most of the patients, it is usually a reason for hospital admission, and patients need prompt analgesia. When we are looking at the guidelines, it is relatively clear that there are not exact recommendations for use of analgesics because it is not included in most of the guidelines. If we are looking at NSAIDs, opioids, or epidural analgesia, you can see that mostly analgesics are in favor comparing to control, and all meta-analyses have shown this. If you compare drugs, for example, opioids and non-opioids, or opioids versus local anesthetics or versus paracetamol, you can see that there is this diamond is on a side of the opioids. If we compare epidural analgesia, we can see that biggest was improvement in 24 hours is with epidural analgesia, and that the results with the opioids are similar to results with the NSAIDs. What about parenteral hydration? This is also one thing we have to start with at the very beginning of a treatment of our patients. So it is very important to give early fluid resuscitation within 24 hours. And usually this parenteral hydration should be started with a Ringer's lactate, 5 to 10 milliliters per kilo per hour, and then 1.5 to 2 milliliters per kilo per hour. So this is used for pancreatic, for prevention of necrosis because of improvement in pancreatic circulation. So comparing Ringer lactate versus normal saline, you can see that there are no differences in mortality and SIRS, but if we are using Ringer lactate, we have a lower risk of intensive care unit admission and a shorter length of stay in the hospital. The next, we like to start at the very beginning on hospitalization is nutrition. So what's the question about nutrition? In mild acute pancreatitis, there is little influence on nutritional status and metabolism, but in severe acute pancreatitis, there is increased energy expenditure, hypermetabolism, protein catabolism, and we really need nutritional support. According to Aspen guidelines on clinical nutrition published 2 years ago, I will just want to remind you that in patients with acute pancreatitis and the inability to feed orally, enteral nutrition shall be preferred to parenteral nutrition. And oral feeding shall be offered as soon as clinically tolerated. So we start with the enteral nutrition, and it should be followed by oral feeding. If we are looking at the study, we did one study in our center. It was published in Cochrane database of systematic reviews, and we have shown that enteral nutrition comparing to non-nutritional support is favorable. This was shown in this meta-analysis, but also when we compare the effect of total enteral and total parenteral nutrition in patients with severe acute pancreatitis, it is clear that total enteral nutrition is favorable if we are looking at the outcome of infection, but also if we are looking as the outcome at MOF, or if we are looking at mortality, or if we are looking at the length of stay. So all these meta-analyses have shown that the total enteral nutrition is favorable. What about immunonutrition? There are some studies with immunonutrition, and mostly immunonutrition stimulates immune cells, and it can reduce the harmful immune response. So it is still not part of clinical guidelines, but almost all the studies have shown that that immunonutrition comparing to classical enteral nutrition is favorable. And it is also favorable comparing to total parenteral nutrition or no nutrition. So if we are looking at the outcomes, there are less infectious complications, there are less organ failures if we are using immunonutrition. What about probiotics? There were many controversies about the probiotics in acute pancreatitis, but recent studies have shown that it improves barrier function and it accelerates recovery of intestinal function. So if you are looking at the recent studies, so if we are using probiotics, length of hospital stay is shorter, and also is a shorter time to successful oral feeding, and also a time to abdominal pain relief compared to probiotics with placebo. This is an updated systematic review with meta-analysis that also has shown that there is a better clinical outcome and lower risk of organ failure and shorter length of stay in patients who are treated with probiotics. What about ERCP? ERCP has shown high mortality rate in patients with biliary sepsis, with impacted stones and biliary obstructions, in patients with dilated bile duct cholangitis. And in these patients was recommended ERCP with sphincterotomy and stone extractions in many old studies done 20 or more than 20 years ago. And the new studies, new study published in Lancet has shown the similar conclusions. So severe pancreatitis without cholangitis and urgent ERCP is not indicated. It is indicated only in patients with cholangitis or persistent cholestasis. What about antibiotic prophylaxis in acute pancreatitis? It is well known that drugs penetrate pancreatic tissue and decontaminate the gut to prevent translocations, as imipenem, ciprofloxacin, or metronidazole are those which should be used in these patients. But the reduced infection rates in severe acute pancreatitis have not shown survival improvement. And in patients with severe acute pancreatitis, we have also more infections with Candida species. And so the correlation of pancreatic necrosis is correlated with infection, but studies mostly have shown that that there is not space to antibiotic prophylaxis in acute pancreatitis if we are looking at outcomes like mortality, like infective necrosis, like non-pancreatic infection. And because of this, SGE, EIAP and ACG recommendations are against antibiotic or probiotic prophylaxis of infectious complications in acute necrotizing pancreatitis. The question is that, or the answer is that antibiotic prophylaxis is not recommended for the prevention of infectious complications in acute pancreatitis, and because of this, at the moment we are following these recommendations. What about the symptomatic pancreatic pseudocysts? There are two methods we can use in the treatment of these patients. This is a meta-analysis showing what is happening if we are using transpapillary pancreatic duct stents or transmural drainage. And you can see that this study favors transmural drainage. What about local complications? If you are talking about a walled necrosis, if we have a walled off necrosis, if it's sterile, we don't need a therapy. But if it is infected, we need a therapy. What kind of therapy? The things haven't changed a lot. We have here still results of Panther trial that have shown that in the patients with infected, one minimally invasive step approach is much better than a primary open necrosectomy. And this is including in all the recommendations and also Arvanitakis paper published in endoscopy. What about infected pancreatic necrosis? I will tell you once again that we have to use carbapenems or interventions after 4 weeks. So it is important not to do interventions very early. And finally, comparing SAMs versus plastic stents, if we are looking at our patients, so double pigtail plastic stents are not able to drain solid debris because this nowadays we favor fully covered self-expandable metal stents or lamps because they facilitate to egress large amounts of fluid and debris. In conclusion, I will tell that that there are many investigations and that many further investigations we still need for detection of targeted treatments. We have to think on pro and prebiotics and immunotherapy as a standard part of therapy. And as you can see, there is a bigger role of endoscopy methods in the future comparing to classical surgical methods. Thank you for your attention.
Thanks, Professor Stimac. It was a great overview, and there are many things that come out. There are a few questions, so I will start. As for especially, I think the first part of acute pancreatitis, when you have a sterile inflammation, are you aware of anything on the use of anti-inflammatory agents like anti-TNF? There's a question from the audience asking this.
You know, in a clinical practice at the moment, we are not using these drugs. Maybe in the future it will be something, but at the moment we don't have anything what is evidence based really. No. Okay.
Second short question from the audience on abdominal compartment syndrome.
Yeah.
Do you want to tell anything about that?
Oh yes, abdominal compartment symptom is something that happens in some very severe acute pancreatitis, and I can tell you that in our centers we have some patients who are treated with this method, and we have a good results with this. But this is we can say from the point of gastroenterologist, it is a relatively aggressive method, but for more severe patients it helps because you know that in abdominal compartment syndrome you have this big intra-abdominal pressure, and sometimes it can save a life if you do this. So we are doing this for the patients who are most severe. No.
Final, your very short comment on is it dangerous to use probiotics in some situations? There was the ProPatria trial from Mark Besseling and colleagues, and they actually had an increased rate of non-ischemic damage in the intestine with probiotics. So, do you think it's still dangerous in a way?
No, but the things change. You know, it was a story about this that probiotics are dangerous, but later with much more new studies. I think that this is one isolated study that has shown this. Most of the newer studies have shown that probiotics can be helpful, and in that way we really do not have to be afraid of using probiotics.
Okay, thanks a lot, really, Davor, and I think we move to the next talk.
Thank you.
Yes, thanks a lot, and we move forward. And the next talk will be given by Dr. Rex Van Hin Hui. He has studied with his team or performed a systematic review about the thoracic epidural analgesia in the treatment of acute pancreatitis, and we will hear the results. Please.
So hello, I'm Dr. Rex Hui from Hong Kong, and I'm very happy to be here today to share our systematic review on the use of thoracic epidural analgesia in acute pancreatitis. So first of all, I do not have any relevant financial relationships to disclose. So as an introduction, we know that severe abdominal pain is a cardinal feature of acute pancreatitis. And despite combinations of different analgesics, breakthrough pain is very common in acute pancreatitis. Thoracic epidural analgesia, or TEA, has been studied as an advanced analgesic strategy for acute pancreatitis. So aside from pain control, TEA also has some secondary effects of splanchnic vasodilation and improvement of pancreatic microcirculation. So animal studies have suggested that TEA can reduce inflammatory response, reduce disease severity, and also improve survival in acute pancreatitis. Accordingly, TEA has been studied as a potential disease-modifying therapy for acute pancreatitis in some pilot trials. So we aim to perform a systematic review on this topic. So the primary objectives of our study are to assess the safety of TEA in acute pancreatitis and to assess the potential impact of TEA on clinical outcomes in pancreatitis. A secondary objective is to assess the impact of TEA on pain control in acute pancreatitis. So this study was performed in accordance to PRISMA guidelines, and we searched a few databases from inception till September 2021. And we used a combination of the terms epidural analgesia and acute pancreatitis and their synonyms. So we included all original articles, including randomized trials, cohort studies, case control studies, and case series. And the risk of bias in our study were evaluated by standardized methods. So this chart shows our study selection process. So we started off with 651 articles, and after exclusion, based on our exclusion criteria, we finally ended up with 8 articles in our systematic review. And this graph shows very well the studies that we have included. So we can see that there are a range of different studies, including case series, some randomized trials, cohort studies, and also retrospective and prospective cohort studies. So the technique of thoracic epidural analgesia was quite standard in different studies, whereas the duration of TEA varied between the studies. So 5 studies looked at the safety of TEA in acute pancreatitis. So one measure was the incidence of epidural-related hypotension. And the incidences of epidural-related hypotension range from 0% to 37.5% in the studies. But nonetheless, all the patients responded well to intravenous fluids or vasopressors even after they develop hypotension. And another safety outcome was the incidence of post-procedural epidural hematoma or epidural abscess, and no incidences of these adverse outcomes were documented. So this chart shows the length of stay and in-hospital mortality in the different studies. So the length of stay was quite variable and was not well reported in all studies. In contrast, the in-hospital mortality was also quite variable. But in the newer studies after 2015, the general mortality rate was lower than 10% in all the included studies. So now we move on to look at the studies that specifically mention some outcomes in acute pancreatitis. So in this 2018 cohort study, we see that mortality in the TEA group was 4% versus mortality of 22% in the non-epidural group. And this was a significant association that remained significant in multivariate analysis and propensity score matching. However, this result was not repeated in 2 other studies. So in this 2019 randomized trial, we see that the mortality was 6.6% in the TEA group versus 12.5% in the non-epidural group. But this was a non-significant difference. And finally, in this 2015 randomized trial, we see that there were no in-hospital mortality in both the TEA or non-epidural groups. So hence, no association to be drawn. So the studies also showed that TEA was associated with lower instances of acute mesenteric ischemia, lower instances of acute kidney injury, and reduced procalcitonin. Nonetheless, TEA had no associations with abdominal complications or infectious complications. So only one study looked at the impact of TEA on acute pancreatitis outcome of pancreatic perfusion. And they measured this through using CT perfusion scans. And they defined an increase in 20% of perfusion as an improvement in perfusion. And a significantly higher proportion of patients in the TEA group had improvement of pancreatic perfusion versus controls in this study. So finally, on the outcome of analgesia, different scales were used for determining the analgesic effects in the studies. But nonetheless, over 87.5% of patients in all these studies had satisfactory pain control. So this study, this chart shows the risk of bias. So we can see that the overall risk of bias was moderate to high in all studies, mainly due to risk of bias in outcome measurement and also in confounding. So in our discussion, we see that TEA is safe in acute pancreatitis, and nonetheless, we did not see any episodes of epidural hematoma or abscess, but these are rare complications and we may need some larger studies to study these safety outcomes. We also see that there were instances of hypotension, but these were all easily managed by vasopressors or IV fluids. And the combination of local analgesics and opioids will likely be the ideal regimen of TEA in these patients, because this combination will likely lead to lower incidences of hypotension. So we see that the evidence of TEA on mortality in acute pancreatitis is mixed. So one cohort study showed some significantly reduced mortality in TEA groups by 5-folds, but 2 other clinical trials did not show significant differences, although the trials were quite small in size. So one study also showed clear radiological evidence of improving pancreatic perfusion. And TEA was also shown to be efficacious in analgesia for acute pancreatitis. But regarding our limitations, we saw that the included studies all had moderate to high risk of bias, and the data was quite heterogeneous, which precluded any meta-analysis or subgroup analysis. So to conclude, TEA is safe in acute pancreatitis. It is effective for pain control, may improve pancreatic perfusion, and it may also improve some adverse outcomes, including mortality. Nonetheless, large-scale, high-quality trials will be warranted to further study the use of TEA in acute pancreatitis. So thank you very much, and this is at the end of my presentation.
Thank you very much for this nice review and a very nice presentation as well. I don't see any questions from the audience. So I will ask you one, what is now your clinical practice in terms of using TEA? Do you use it for the moderate and severe acute pancreatitis patients, or how do you select the patients you use a TEA?
I mean, in our locality in Hong Kong, I think one limitation in this is where the patient is located, because very frequently, like acute pancreatitis may be managed in a gastroenterology wards, to be managed by the surgeons. And in these cases, it would be very rare for us to actually consider the use of TEA. Mm-hmm. But if the patient was actually admitted to the ICU with some prolonged care and with the involvement of some intensivists or some anesthesiologists, then we would be more likely to consider the use of this. So I mean, when we went through this review, we actually saw that it's something that has been explored many years ago. So TEA is a very common procedure that's very common for anesthesiologists. Yeah. But if we don't involve them, then it's just very rare to be used. I mean, that's what we see in clinical practice.
Mm-hmm. Yeah, exactly. One more question: how to determine the reduction of mesenteric ischemia from
yes. So yes. So I think that was in that trial. I think in that study, the mesenteric ischemia was actually defined by whether they need any whether they need to go in for any surgery, etc. So I think that was the outcome definition in that study. But okay. Indeed, I think in the studies that we reviewed, it's not very standardized and it was highly variable. So I don't think it's very likely that we can compare the studies very well. So that's why we need some of these large-scale trials are ongoing.
Yes. Okay. Thank you again, and we will move forward. Gabriele.
Thank you, Joanna. Thank you. So we move to next presentation. We'll have Dr. Cristina Patoni. Cristina is an Italian name, but I think she's working in Hungary, unfortunately, and she presented a meta-analysis on the effect of anticoagulants on the severity and mortality of acute pancreatitis. So please, Cristina, the floor is yours.
Good afternoon, everyone. Thank you for the opportunity to present our results at the EPC 2022 meeting. Our work is a meta-analysis about the safety and efficacy of anticoagulants acute pancreatitis. I have nothing to disclose. We all know that acute pancreatitis is an inflammatory disease, and as a consequence, it is associated with vascular injury, activation of coagulation, and increased leukocyte rolling. Its severity can range from mild local inflammation to severe systemic complications. There is a close relationship between the development of thromboembolic events and the severity of this disease. There is an increased risk for thromboembolic events, and this is due to the anatomic relationship of the large mesenteric vessels to the pancreas, the prothrombotic nature of acute inflammatory reaction, along with contributions from the systemic response to the pancreatic injury, hypovolemia, and fluid shifts. Nevertheless, the management of acute pancreatitis is focused on supportive care measures based on fluid therapy, nutritional therapy, and pain management. Although anticoagulants are frequently prescribed to acute pancreatitis patients in clinical practice, the authoritative guidelines in the field do not make specific recommendations on their use. Heparin, besides their anticoagulant effects, have also the ability to regulate inflammation by reducing the release of cytokines and inflammatory mediators. Moreover, they can suppress the activity of digestive enzymes, and by this, they can decrease the severity for acute pancreatitis patients. So our aim was to assess the safety and the efficacy of anticoagulant therapy in the treatment of acute pancreatitis. I will just briefly present the methods. We used the PICO framework. Our search was conducted on 3 databases, and the search key had 2 main concepts, pancreatitis and all anticoagulants related synonyms. We considered eligible all randomized controlled trials and observational studies. Here we have our PRISMA flowchart. Our search retrieved a total of almost 8,000 articles, and in the end, we identified 9 reports eligible for our systematic review, and 7 were included in the meta-analysis. From the 7 studies that were included in the meta-analysis, 4 were RCTs, and the population was represented by moderately severe and severe cases, and 6 out of 7 report the use of low molecular weight heparin therapy. Now I will start to show you some of our results. But first, let me introduce you a bit the design of our plots. We report the odds ratios or the mean differences together with the 95% confidence intervals. Our analysis regarding mortality revealed that patients who received anticoagulants have 43% odds for dying compared to the control group, and the result is statistically significant. Clinically, the mortality in the intervention group is half by comparison to the control group. The subgroup analysis we performed only for RCTs revealed that a 76% decrease in mortality can occur in the anticoagulant group. Here we have a subgroup that we performed for the severity. Although it is based on a limited amount of data, we can see a potentially higher benefit in severe cases by comparison to mild to moderately severe ones. Moreover, we performed subgroup analysis for the dose of low molecular weight heparin. The odds ratio for the mortality rate was slightly better for patients who received a therapeutic dose of low molecular weight heparin compared to those who received the prophylactic dose. However, the test we performed for subgroup differences indicates we should interpret carefully the result because of low number of studies. Highly related to mortality, the multiple organ failure analysis shows in the RCT subgroup that the administration of anticoagulants can reduce multiple organ failure in 67% of the cases. Also, among the organ failure, we had the possibility to evaluate acute kidney injury. Only 3 studies report this outcome. 2 of them are RCTs and 1 is a case control. And our results suggest that administration of anticoagulants is associated with lower risk of acute kidney injury. The need for endoscopic or surgery intervention is among the evaluated outcomes. And our analysis revealed that anticoagulants lead to significantly lower rates of invasive endoscopic or surgery procedures, reducing almost half for the patients for the need for intervention for the anticoagulant in the anticoagulant treatment group. We performed subgroup analysis based on the severity, but again, data was limited. We can see that for the severe cases in the anticoagulant group, the need for endoscopic or surgical intervention is reduced by 30%, and in the moderately severe cases, the anticoagulants reduce the need for intervention with 70%. Yet there is only one study included in this subgroup. Although overall result is not statistically significant, available data suggests that initiation of treatment early in the course of the disease has improved results compared with delayed intervention. The length of hospital stay was significantly shorter, with almost 5 days in the anticoagulant group. Bleeding events were reported only by 2 studies from the systematic review, so we couldn't perform a meta-analysis. Both of them report fewer cases of bleeding in the anticoagulant group. Regarding the implications for research and practice, further research is needed to assess the benefit of anticoagulant therapy in mild pancreatitis, and the studies should report the safety outcomes. As for implications for clinical practice, we should add anticoagulant treatment in moderately severe and severe cases of acute pancreatitis because of their benefits. In the end, I would like to emphasize the strengths and limitation of our paper. There are several strengths. We have increased the level of evidence because we could perform subgroups for all RCTs. For all outcomes, we have more than 200 patients included in the analysis. There is no heterogeneity for RCTs when we pull the results, and we used robust methodology. As for the limitations, we have low amount of data for moderately severe subgroup analysis, low reporting rate of safety outcomes, and we couldn't perform the publication bias because we have less than 10 studies. To sum up, anticoagulants decrease major complication rates in moderately severe and severe acute pancreatitis. Prophylactic and therapeutic doses might have similar effects. Anticoagulation initiation early after acute pancreatitis onset might lead to enhanced benefits. Further studies are needed to assess the effects of anticoagulants in mild acute pancreatitis and confirm their safety profile. In the end, I would like to thank to Translation and Medicine Semmelweis team, and special thanks to Professor Peter Hegyi and to my supervisor, Dr. Balin Terox, Dr. Peter Hegyi, Dr. Stefania Bunduk, and all my other colleagues. Thank you for your attention.
Thank you, Christina. Very nice presentation. And I was impressed by the lack of heterogeneity in most of the analysis, so it's quite reliable. So we have one question from the audience, that is whether you managed to find data on D-dimers levels or data on coagulation that somehow help to select the right patients.
Well, unfortunately, the laboratory parameters are not reported in all of our studies. Only one study reported the D-dimer level, for instance, and we couldn't make an analysis for this.
Okay, and I have a second short question is, so where do you want to go from here? And knowing your group that is able to run ambitious studies, are you planning to run further, better designed trials or something like that on the early use of anticoagulants in acute pancreatitis?
Yes, of course, we would like to do this.
Okay, and do you think this should be done in all acute pancreatitis patients, or would you select a certain group?
Well, this was our aim. We wanted to assess the severity for all the stages. we could perform subgroups only for moderately severe and severe cases. We didn't find data for the mild ones. So I think further analysis should be done for the mild ones. And of course, because of the fact that it was proven to be efficient for the moderate and for the severe, it should be added as in our current guidelines, as current practice.
Okay, thanks a lot for your presentation.
Thank you.
Yes, thank you, Christina. And then it's my great pleasure to introduce the last speaker of this session, who is my co-chair, Professor Gabriele Capurso. We all know how difficult it is to predict the severity of acute pancreatitis. And Gabriele and his team have now performed a systematic review and meta-analysis with the pre and post-test probability assessment to address this issue. So Gabriele, the floor is yours.
Dear colleagues, the topic of the talk regards the predictive scores for acute pancreatitis severity. So, as you all know, the severity of acute pancreatitis is a post-hoc definition. So, after the disease course, we are able to know which patients developed a severe acute pancreatitis with prolonged organ failure according to revised Atlanta criteria. These patients have a higher rate of mortality, but only represent a small quote, less than 20% of all acute pancreatitis cases. That is why we should be able to predict as early as possible who these patients are. So we need something that is able to turn the pre-test probability, that is the prevalence of severe acute pancreatitis, into a post-test probability that is clinically meaningful. As you see in this Fagan nomogram, we always start when we have a patient with a pre-test probability. So let's say it's 20% for the probability of a severe acute pancreatitis. And if you have a very good score or biomarker or test, you are maybe able to reach an 80% probability of having a severe acute pancreatitis if this test is positive. Unfortunately, this is not the case in acute pancreatitis. We would need markers that are simple, can be used, and increase substantially the probability of severe course if positive, or decrease it substantially if negative. However, the clinical usefulness of this test is debatable, and there are no systematic reviews or meta-analysis analyze them in a systematic fashion after introduction of RAC. So we aim at performing a meta-analysis of these scores to investigate their ability to modify the pre-test probability of severe acute pancreatitis. As methods, we use a standard search for the papers. Then we pull the pre-test probability, so the prevalence of severe acute pancreatitis, to calculate it. And finally, we calculated the post-test probabilities according to these test performances. We ended up with 41 studies after research. And of these studies, the majority employed BSAP, then Apache 2, Ransom, Sears. Only 2 studies used all the 4 scores, and then we concentrated on 15 of them using 3 scores, BSAP, Apache 2, and Ransom. So as for each score, you see here the performance of BSAP. There were 39 studies with 12,000 patients, and the pre-test probability, so the pooled prevalence of severity, was 18.7%, sensitivity 74, specificity 81%, always with a very high heterogeneity we couldn't account for in sensitivity analysis. So this is the performance of BSAP in these 12,000 patients. You start with the pre-test probability of 18%, and if it's positive, you end up with 48% probability, if negative, with 7%. And this is the distribution of patients according to the positive or negative test, and either true positive, true negative, and so on. Apache 2, 29 studies, 9,000 patients, pre-test probability 16%, sensitivity 78, specificity 79. You start with a 19% probability and stop with 44% if positive, 5% if negative, with the performance you see here. Ransom, 26 studies, almost 10,000 patients again, starts with an 18% probability, sensitivity 79, specificity 81. And this is the actual performance. If positive, you end up with a 50% probability of severe acute pancreatitis. If negative, it is 6%. And this is again the distribution of patients according to this performance. Finally, SEERS, 8 studies, 2,000 patients. There was a slightly higher pretest probability, 25%, sensitivity 74, specificity down to 62. So you start with 25, end up with 40% if SEERS is positive, or 12% if it is negative. And again, the distribution of patients according to the performance of SEERS. We also looked at the 15 studies I told you employed 3 scores to compare their performance. There were 6,200 patients in these 15 studies. They had a full probability of severe course of 19%. So this is the pretest probability. And you can see here that the performance was extremely similar. The highest post-test probability, if positive, was for Ransom, 53%, BSAP, 51%, Apache 2, 47%. And strikingly, exactly the same post-test probability, if negative, for all these 3 scores. So, in summary, the most commonly employed scores to predict severe acute pancreatitis course, according to revised Atlanta criteria, perform poorly and do not help decision-making substantially. With the pretest probability of some 20%, with the positive score, you only turn into 50% or around that if the test is positive, or 6% if negative. So I think we really sorely need new scores that take into account more patients' variable, or either circulating biomarkers, or a dynamic evaluation of the disease course, as done in some of these papers, or especially novel approaches such as artificial intelligence algorithms to reach better performance with the clinical meaning. Thank you for your attention.
Thank you, Gabriele. Excellent talk. And well, it is hard to predict the severity of acute pancreatitis, isn't it? I usually like to use the BSAP score, but well, it performs as good or bad as all the others, right? Do you see any hope in the horizon for these biomarkers? Anything that you have in your mind that would help us with this?
I think, first of all, if they all perform the same, then we should use the simple thing. So BSAP is probably simple. So I agree with you that probably why not? And SEERS is very simple and is slightly maybe worse, but maybe I would use that. And I think that clinically we would really need to get rid of very mild patients, and in the future probably really send them home like we now do with acute diverticulitis after 1 day or so of observation. And so this is what we need now, and it is very you know, I saw the paper that just came out from Peter Ige group, from a Hungarian study group on use of artificial intelligence, and use an algorithm that's called EASY, and it looks really easy. It is available online, and I think we need something like that, something that, you know, with an app on the phone, in the first day in the emergency room, we can say this guy can go tomorrow, and maybe, you know, we'll call him to check, and then treat in the hospital a minority of patients that it will be harder to see who's going to develop a severe form, but maybe we will need to monitor them for a longer time. But yes, we are not there yet.
Yes, exactly. That is the great question, that at least to be able to detect those patients who are for sure having the mild disease, and to sending those home. That would be great. Okay, thank you so much, Gabriele, and I think with this we will be able to close this, I think, very interesting session. I want to first of all congratulate the organizers to organizing EBC in such difficult times, and then also to thank all the speakers in this session, as well as the audience for all the questions and discussions. I want to also wish for, especially for all the Scandinavian people, happy midsummer. We are in the middle of that at the moment. We have the public holiday in Scandinavian countries at the moment, and happy midsummer to all. And I hope to see you all soon, also in person. Take care, and hope to see you soon. Thank you so much.
Thank you. Skål for tonight.